Hello everyone, welcome to my channel Learn in Minutes, and today let us briefly review this topic, pathologic tooth migration. I will be covering up the topic under the following outline: definition, etiopathogenesis, pathologic tooth migration versus drifting, the various treatment modalities, prevention, and finally conclusion. Going on to the definition. Pathologic tooth migration is defined as tooth displacement that results when balance among the factors that maintain the physiologic tooth position is disturbed by periodontal disease. Two major factors that play an important role in maintaining the normal position of the teeth are the health and the normal height of the periodontium and the forces exerted on the teeth. Let's consider the health and height of periodontium. It is a proven fact that periodontal destruction is usually a significant factor in the etiology of pathologic tooth migration. It was noted that significantly more bone loss and more attachment loss was seen with respect to migrated teeth. Now, if we consider what are the various factors that are exerted on teeth, it could be grouped into two: forces from the soft tissue and forces from the hard tissue or the teeth. Going on to the forces of the soft tissue. So, the forces from the cheek, the lips, either the lower or the upper lip, tongue, etc., are the forces of the soft tissue. Forces from the tongue and lip vary greatly, but the tongue pressures are usually several times greater than the lip and cheek pressure. Therefore, it has been well researched fact that pressure from soft tissues can move teeth, particularly those with weakened periodontal support. Going on to the next factor. As early as 1933, Hirschfeld described pathologic migration of teeth resulting from pressure from inflammatory tissue in the periodontal pocket. Then subsequently, case reports and case series mentioned this phenomenon and often described tooth movement in a direction opposite to the deepest part of the pocket. Apart from this, at times, aberrant frenal attachments too lead to pathologic tooth migration. Also, oral habits such as lip biting, tongue thrusting, nail biting, thumb sucking, playing wind instruments, etc., have been associated with pathologic tooth migration. Here, it is important to remember that the duration of force is more important than the magnitude. Greater the duration of the habit, greater the potential to move teeth which have a weakened periodontal support. It has also been shown in various studies that gingival overgrowth caused by severe inflammation or drugs such as phenytoin, cyclosporin, or drugs such as calcium channel blockers used as antihypertensive drugs tend to cause gingival enlargement and movement of the teeth from their normal physiologic position. So these are the various factors related to the soft tissue that we need to keep a check on. Going on to the forces of occlusion. Loss of tooth morphology or cuspidal inclination due to parafunctional habits can lead to pathologic tooth migration. Also, the presence of full complement of teeth is very much necessary to maintain balanced occlusal forces. The next factor would be the physiological tendency towards mesial migration of teeth, the nature and the location of the contact points, any destruction of the contacts due to caries, atresion, faulty restorations, etc., can again lead to disturbance in the balanced occlusal forces. Proximal incisal occlusal atresion, and finally axial inclination of the teeth are the various factors that influence the forces of occlusion. The most common cause of pathologic tooth migration would be a posterior collapse bite, which can result due to the failure to replace the lost first molar. So let us see what are the various sequelae that result when you fail to replace the missing molar. The second and the third molar tilt mesially. The premolars start tilting distally. This leads to a decrease in the vertical dimension. Mandibular anterior teeth start to drift lingually. There is an increased anterior overbite, and the mandibular incisors strike the maxillary incisors near the gingival area and traumatize that area. Slowly, the maxillary incisors are pushed labially and laterally. Then they extrude, diastemas are created. Therefore, to concise all these, there is a disturbance in the balanced occlusal forces leading to migration of teeth pathologically. Hence, concising all the etiopathogenic factors, we can say that loss of periodontal support is the main factor that leads to pathologic tooth migration. Apart from this, periodontal or periapical inflammation, gingival overgrowth, pressure from oral musculature, malpositioned frenal attachment, occlusal factors, the list of occlusal factors that were specified in the previous slide, and finally, trauma from occlusion can all be listed under the etiology of pathologic tooth migration. So now let's see what is the difference between pathologic migration versus drifting. Now, in both pathologic migration and drifting, we see that there are abnormal forces. This is a common factor. But what differentiates both these phenomena are that abnormal forces are acting on periodontally weakened teeth in pathologic tooth migration, whereas in drifting, abnormal forces are acting on teeth with a healthy periodontium. Now let's try to concise the various treatment modalities. Treatment modalities can include definitive pocket therapy. Then, if the pathologic tooth migration is localized to just one or two teeth, local drug delivery could be an option with antibiotic fibers, etc., that can be placed in the gingival sulcus. Restorative or prosthetic camouflage can be done in mild to moderate cases. Orthodontic treatment, but with minimal detrimental effect on periodontium that at least has 50% or more support, can be initiated. And finally, in teeth which have severe pathologic tooth migration, extraction and replacement with a fixed prosthesis is what is advocated. The Journal of Indian Society of Periodontology has summarized the treatment plan based on the severity of pathologic tooth migration. So, in mild to early cases where the diastema is less than 2 millimeters due to periodontal disease, the treatment plan would include scaling, root planing, and if required, a flap. In moderate cases, where along with the diastema you also see a certain amount of extrusion and flaring, periodontal therapy plus orthodontic forces, the point to be remembered here is to use light intrusive forces and make sure that there is at least 50% or more of periodontal support. But in severe cases where the diastema is greater than 2 millimeters, along with that there is severe extrusion, flaring, all due to periodontal disease, the treatment modality would include extraction of that particular tooth and initiate a fixed prosthodontic therapy either in the form of an FPD or an implant. So, this summarizes the entire topic of pathologic tooth migration. Thank you for your patient listening.